Evening, my name is Michael Silagy. I'm an obstetrics and gynecology registrar from Australia. Thank you for the opportunity to speak at ICS 2021. I'm presenting the short and long-term outcomes of Johnson & Johnson mid-urethral slings at a large tertiary health network. I've been self-funded to attend, and you can see our relevant disclosures. The aim of this research was to review the short and long-term complication and readmission rates in women who underwent J&J mid-urethral sling procedures. This retrospective audit with patient self-selected follow-up was performed in the context of a large class action brought to the Federal Court of Australia. All patients who underwent a sling procedure using a J&J product were identified through a large coding search as part of the legal subpoena. Both paper and electronic records were subsequently reviewed. As part of the legal action, all patients were contacted by the health service via post and offered the opportunity to attend a clinical review through a dedicated mesh support service. They were also contacted and invited to join the class action by the legal firm. From 1999 to 2017, 858 women underwent 869 mid-urethral sling procedures with J&J products. 72% of cases were retropubic slings, with 331 TVT classic slings and 284 TVT exacts. TVT obturator slings were used 126 times, with TVT Abrivo and TVT Secure the remaining slings. Procedures were performed by both the gynecology-urogynecology unit of the hospital, as well as the health network's urology unit, who performed 62 procedures, making up 7% of cases. The median age of patients was 58 years and 55.5 years respectively. Over half of the patients who had surgery through the gyne-urogyne unit had concurrent laparoscopic or pelvic floor surgery, compared to only 25% of the urology group. Patients were followed up in clinic for an average of 2.6 years, but ranging up to 19 years, with a chart review for the purpose of this audit occurring at up to 21.8 years. At their most recent clinical review, only 4.3% of patients reported ongoing stress incontinence symptoms, and 16% of patients reported urinary urgency symptoms, which could be either new or de novo urgency. When looking at short-term readmissions, 4.8% of patients had voiding dysfunction requiring discharge with an indwelling catheter following their procedure and were readmitted for a planned trial of void. This occurred more commonly in those who had concurrent pelvic floor and laparoscopic surgery compared to standalone sling procedures, 2.1% versus 7.6%. Sling loosening within 30 days was required by 14 patients, and one patient required a division of their sling within 30 days. Again, these were seen more commonly in those who had concurrent pelvic floor surgery. There were 7 patients readmitted for infection complications, either surgical site infection or urinary tract infection, and 3 patients admitted for bleeding complications. 1 patient was readmitted for pelvic pain, which spontaneously resolved and didn't require any investigation. There was 1 patient death due to complications of a perforated viscus, which was unrelated to their sling procedure. Readmissions beyond 30 days were captured through the audit process. 14 patients required sling division beyond 30 days, and 6 other patients were readmitted for investigation of voiding dysfunction, but didn't require further treatment. 13 patients underwent a repeat sling procedure, with 4 other patients receiving alternate treatments for stress urinary incontinence, with an overall rate of repeat surgery of 1.9%. 23 patients were readmitted for mesh complications. 20 of those were found to have a mesh exposure, with 3 patients found to have mesh erosion, 2 of these into the urethra and 1 into the bladder. There were 6 patients who were investigated for bladder or pelvic pain, with 4 of these having no mesh seen at the time of cystoscopy. 1 patient received bilateral pudendal blocks for a pudendal neuralgia, and the other had an injection of steroid into an area of palpable mesh. 81 women contacted the dedicated mesh support service for further information, and 55 women accepted the offer of clinical review, which included a questionnaire with patient-reported outcomes, clinical history and examination, uroflow and post-void residual measurement, and a translabial ultrasound of the sling. Following this review, 20 patients were reassured and were discharged. 3 patients reported ongoing stress incontinence symptoms, for which 1 has undergone a bulk and mid-injection procedure. 1 patient had a pessary with support inserted, and the other declined further management. 2 patients reported voiding dysfunction with a slow stream and incomplete emptying, 1 thought to be due to pelvic organ prolapse, which improved with insertion of a Gellhorn pessary, and the other thought to be due to vaginal atrophy treated with vaginal estrogen. 5 patients reported mesh exposure and pain. 2 of these have since undergone total mesh excision. The first was performed via a vaginal and laparoscopic approach and was found to have a pre-pubic placement of the left arm of a TVT exact. Following its removal, she subsequently developed worsening stress incontinence and is awaiting a bulk mid-procedure. The other patient underwent total mesh excision and bilateral groin dissection for removal of a TVT obturator. 2 patients who reported pain with mesh exposure have declined any further surgical management, and 1 is awaiting a face-to-face review which has been delayed due to the COVID pandemic. 17 patients reported urinary urgency symptoms, 4 of which have undergone intravesical injection of Botox. 1 patient has reported recurrent UTIs and pelvic pain and has been commenced on prophylactic antibiotics. This audit was a complete audit of every J&J mesh sling procedure used at a large tertiary health network. Whilst data extraction was difficult due to no dedicated mesh registry at the time of the procedure, this has since been introduced in Australia in 2020. There is, however, limited ability to capture patient-reported outcome data. Follow-up of patients was through both private and public sectors, so there was limited access to that clinical follow-up, but readmissions through the health network were captured in this audit. Readmissions at other health networks or in the private sector, however, were unable to be captured and may result in an underrepresentation in readmission rates. Finally, being a teaching hospital, the learning curve and experience of primary operators was not able to be identified, and this is a known risk factor for operative complications. Overall, this tertiary health network's experience with J&J slings over a 21-year period had complication rates similar to that published in the medical literature. There was a reoperation rate of 1.9% for recurrent stress incontinence and 1.6% for both sling loosening and sling division. 2.3% of patients had repeat surgery for mesh exposure, 0.3% for mesh erosion, and total mesh excision was required in 0.2% of patients. Persisting or de novo urinary urgency was seen in 16% of women.